Dr. Stearns, Dr. Sanchez, ladies and gentlemen. I have nothing to disclose. This publication is a little dated by Dr. Schanzer, but in 2011 he showed us that just because you did an EVAR didn't mean that you had fixed the problem. And 5 years following EVAR, there was a 41% sac enlargement. And of this, 31% were done outside the IFU. And sac enlargement was more common in cases where we did not follow the guidelines. Other independent predictors of sac enlargement were age greater than 80, aortic neck diameter greater than 28, aortic neck angle greater than 60, and common iliac artery diameter greater than 20. So the most common cause of failure of EVAR is the anatomy of the aneurysm. More recently, Mark Schemerhorn showed us using Medicare data that aneurysm rupture occurred about 5.4% following EVAR versus 1.4 in open repairs. And this was probably an underrepresentation of the facts. This emphasized to us that there was an ongoing need for surveillance of EVAR lifelong. And as you followed these patients for a longer period of time, you found that more of them failed. So what are some of the characteristics of failure, such as this, there's an acutely angulated neck, or a short angulated neck, and all of us are familiar now with the potential for failure for these sorts of patients. And here is another example of where a stent graft was placed and it collapsed and occluded. And then, of course, we come across these patients where there is no access, and these are all examples where open repair perhaps should have been considered right from the get-go rather than try to force something which wouldn't fit. So lessons learned from surgical conversion after failed previous EVAR, fairly recent publication. These authors showed us that the mean interval was about 5 years. These were large aneurysms, and the mechanisms of failure were type 1A and type 1B, accounting for about 60%, and the remainder were type 2s and 3s. About half of them were asymptomatic, and half of them presented with rupture. Total graft explant early in our experience was high, 42%. Partial graft explant, which is now much more common, in this particular paper was 31%. It's a fairly high 30-day mortality of 20+%, of course higher in patients who present in shock and those who have suprarenal barbs. So what are some of the technical tips for conversion to open repair? There's no major difference between transabdominal or retroperitoneal approach. This is a two-attending case. Don't try to be shy to request senior help. Expect severe periaortic inflammation. Be familiar with the device that is being explanted. Use of soft tissue bipolar electrocoagulator from Medtronic has been helpful in my experience. And intraoperative decision-making will frequently make the difference between death and a live patient at the end. I established balloon control of the aorta, similar for ruptured aorta that Dr. Sharif Sultan just showed us. I use a 12 French sheath, 45 centimeters long, and use a 32 or a 36 Coda on a rigid wire. You inflate balloon for a raging type 1. In all others, you leave the balloon in place, ready to inflate in case you need to. We open the sac without clamps. For suprarenal fixation, the syringe trick, which I'm going to show you, does work, and you must have metal cutters available for partial graft excision, except where you're dealing with an infected graft where complete removal is desirable. When you start to sew, you take large, deep bites on the posterior wall to incorporate the endograft remnant and the native aortic wall. This is the trick using the 20 cc syringe. You saw off the top. You take a tape and you bind the distal portion of the endograft, put the tape through the 20 cc syringe, slide the syringe up until you capture as much of the endograft as possible, hopefully the entire bit, and then you can remove it safely without tearing the suprarenal aorta. This is the case where you use metal cutters for hybrid reconstruction, and unless it's an infected graft, this is a very wise thing to do. Don't try to pull out the suprarenal barbs, just cut the graft where you have a bit of a neck, and sew your graft on, leaving a remnant of the old endograft in. What is semi-conversion? This is graft preservation after failed EVAR, mostly for type 2. Aortic clamping is not necessary. The aortic sac is opened, and the vigorous bleeding from the lumbars is oversewn. Aortic neck banding may be necessary. 30-day mortality is a very reasonable 5.3% with a morbidity of 13%. Endoleak recurrence is 7%. Overall survival, again, a very respectable 85%. It's a good alternative to graft explant, and aortic cross-clamping may be a prohibitive risk. With the advent of PMEG and TAMBI, which you just heard, the need for open conversion for type 1A endoleak should be needed less often. Thank you, ladies and gentlemen.